Hello friends, welcome to today's lecture on question banks. We'll do question banks from UWorld. So let's start. A 24-year-old woman is being evaluated for chronic fatigue. She has a history of heavy menstrual periods since menarche and also recalls frequent nosebleeds as a child. Her past medical history is otherwise insignificant and she takes no medications. Laboratory studies show a hemoglobin level of 9.2 gram per deciliter, MCV or mean corpuscular volume of 72 FL, and decreased levels of ferritin. Which of the following is the most likely diagnosis? Pause the video and think of the answer. This patient is suffering from microcytic anemia as indicated from her lab studies showing low hemoglobin level with low MCV. MCV lower than 80 indicates microcytic anemia, and also there is decreased levels of ferritin. With bleeding, chronic bleeding in women is indicative for iron deficiency, microcytic anemia. In developed countries, iron deficiency anemia is most commonly caused by blood loss. So, excessive blood loss. So, the patient's history of heavy menstrual periods, that is menorrhagia, since menarche and frequent nosebleeds, that is epistaxis, as a child, further suggests that she is suffering from von Willebrand disease as the most etiology of her anemia. In von Willebrand disease, a mutation results in impaired synthesis in von Willebrand factor, leading to a qualitative defect in platelet binding and aggregation. As a result, patients with von Willebrand disease experience easy bleeding from skin and mucosal sites, including the gingivae, nasal mucosa, GIT, and endometrium. So, the most likely diagnosis here is von Willebrand factor deficiency. The other options are inappropriate, as in choice A. The antiphospholipid syndrome causes a hypercoagulable state that increases the risk of thrombosis and spontaneous abortion. As there is no case or scenario of thrombosis, so the choice A is inappropriate. Whereas the choice B, the factor VIII deficiency causes hemophilia A, and it is a severe form of von Willebrand disease that can also result in factor VIII deficiency, as factor VIII is protected from degradation by von Willebrand factor. However, this patient does not have the characteristic deep tissue bleeding, example bleeding into joints or muscles, or deep GIT bleeding or heavy GIT bleeding with hematuria. This is typically not the case of factor VIII deficiency, which is seen with the clotting factor deficiencies. So the factor VIII is also not the appropriate answer because it will lead to deep tissue bleeding, which is not seen in this case. Now next, the factor 13 deficiency is an extremely rare autosomal recessive disorder that causes clot instability. Affected patients often have delayed and recurrent bleeding after trauma or surgery. It is hemophilia-like bleeding, that is deep tissue bleeding, which is seen in factor 13 deficiency. In fact, in all clotting factor deficiencies, there is cases of characteristic deep tissue bleeding, which is not found in this patient, and hence the choice C is also not the appropriate answer. Now, the immune thrombocytopenia, which is formerly immune thrombocytopenic purpura, produces isolated thrombocytopenia with episodic bleeding that is typically mucocutaneous, example petechiae, purpura, and epistaxis. However, the associated bleeding is unlikely to be chronic and unrelenting since childhood, and since this will also be not the appropriate answer. Next, the choice E. The protein C is a natural anticoagulant protein, and deficiency results in a procoagulant state that most commonly manifests with recurrent deep venous thrombosis, likely the Budd-Chiari syndrome, and since there is no such case, the protein C deficiency is also not the answer. This slide presents the laboratory characteristics of coagulopathies. The first disease is hemophilia A and B. In hemophilia A, there is deficiency in factor 8, whereas in hemophilia B, there is deficiency in factor 9. So, we see that both the factors are the factors of the intrinsic pathway. And when there is deficiency in the factors of the intrinsic pathway, we see that there is prolongation of the PTT, that is the activated partial thromboplastin time, whereas the PT or the prothrombin time remains the normal because it is affected by the deficiency in the clotting factors of extrinsic pathway, that is factor 7. And in this case, since the intrinsic factors is involved, in cases of hemophilia, we see there is prolonged PTT. And since the primary hemostasis is not affected in this case, the platelet count is also normal and the bleeding time is also normal. Now the next disease is von Willebrand factor deficiency. In this case, there is no deficiency or no affection in the coagulating factors. So we see that the PT and PTT are usually normal, but since the platelets are also not being affected, they are also normal, but the bleeding time is increased because there is a deficiency in the or there is decreased attachment of the platelets to the endothelial cells and to one another because of deficiency of the von Willebrand factor, and therefore the bleeding time is prolonged. In the cases of disseminated intravascular coagulation, there is prolonged PT with prolonged PTT and decreased platelet count with prolonged bleeding time. Now, since DIC is a condition involving multiple formation of thrombosis or in the blood vessels or in different kinds of organs, the multiple thrombosis leads to increased usage of the clotting factors and of the platelet, thereby prolonging the PT and PTT with decreased platelet count. Since so many platelets are being used, their count in the circulating blood decreases. Also, since the clotting factors are also being used for the thrombus formation, the clotting factor deficiency also occur, which leads to prolonged PT and PTT with increased bleeding time. Next is uramic platelet dysfunction. In this we see there is normal PT, PTT and normal platelet count, indicating that there is no deficiency in clotting factors and no deficient or no abnormality in the platelet count, but the bleeding time is prolonged. This is due to uremia. What happens that the uremia leads to platelet dysfunction, and this is due to both decreased platelet activation and impaired adhesion to vascular subendothelial cells, leading to prolonged bleeding time. Furthermore, uramic platelets synthesize less thromboxane A2, and the blood vessels in patients with uremia produce greater quantities of platelet inhibitory prostaglandin. And also the nitric oxide produced by the endothelial cells inhibits platelet function, prolonging the bleeding time. Next is the case of heparin administration. In the cases of heparin administration, there is seen that only partial thromboplastin time is increased, whereas PT is normal and the platelet count is also normal except in cases of heparin induced thrombocytopenia, and there is also normal bleeding time. In heparin-induced thrombocytopenia, there is antibodies formed against the complexes of heparin and platelet 4, which activates the platelets and promote a prothrombotic state, thus leading to decreased platelet count in cases of heparin-induced thrombocytopenia. But in cases of normal heparin administration, the platelet count is normal, only PTT is prolonged. Whereas in warfarin use, there is prolonged PT, that is prothrombin time, and there may also be prolonged PTT, but it's weak, that is not so significant. Mainly it's important to remember that in heparin administration the PTT is prolonged, whereas in warfarin administration the PT is prolonged. Rest, there is normal platelet count and normal bleeding time in case of warfarin use. Last is immune thrombocytopenia, that is immune mediated thrombocytopenia. In this there is normal PT and PTT, but the platelet count is decreased due to hemolysis. In this condition there is autoantibody formation against the platelet antigen, specifically GP2A3B, and this leads to decrease in the platelet count due to hemolysis and leading to prolonged bleeding time. Moving to the next question, von Willebrand factor normally binds to which of the following? Stop the video and think of the answer. Von Willebrand factor or VWF primary serves two important roles in hemostasis. The first is the platelet adhesion, and next one is the carrier protein for factor VIII. Von Willebrand factor promotes platelet adhesion at sites of vascular injury by binding to and cross-linking platelet glycoproteins, primarily GP1B, with exposed collagen underneath damaged endothelium. VWF also enhances platelet aggregation, particularly under conditions of high shear stress such as in small vessels. Second function, that is VW, acts as a protective carrier protein for factor VIII that increases its plasma half-life. In the absence of VWF, factor VIII is rapidly degraded in the circulation via proteolytic inactivation. Thus, the answer to this question is collagen. The von Willebrand factor normally binds to exposed collagen underneath damaged endothelium. The rest of the options are inappropriate. A homeostatic fibrin polymer is the end result of the coagulation cascade, and fibrin also plays a role in inflammation and coagulation regulation. It has nothing to do with von Willebrand factor, and therefore it is not the answer. Next, the prostacyclin function both as inhibitor of platelet aggregation and a vasodilator. And protein C is a vitamin K dependent anticoagulant activated by bound thrombin in the presence of endothelial thrombomodulin. Protein C acts together with protein S to inactivate the activated forms of factors 5 and 8, which are necessary for the production of thrombin, and it is not related to attachment of von Willebrand factor 2. Next, the thrombin is produced from prothrombin by activated factor 10. Thrombin in turn converts fibrinogen to fibrin. This or the thrombin also activates factors 5, 8 and 13, and it has nothing to do with von Willebrand attachment. So the answer is collagen. Now this slide presents to you the picture of the two important roles of von Willebrand factor in hemostasis. The first being as a carrier protein for factor 8 and protecting the factor 8 from degradation. Next function is of the platelet adhesion to the subendothelial collagen with the help of the GP1B glycoproteins of the platelet. In this question, a 47-year-old woman comes to the office with a red rash on her chest that has been present for approximately 2 months. The rash is itchy and the skin feels rough to touch. The itching has worsened in the past few weeks and various skin moisturizers have provided no relief. The patient has a history of surgery for bilateral silicone breast implants 10 years ago. Her temperature is 37.2 degrees Celsius. Physical examination reveals induration and swelling over the right breast. Further examination reveals right axillary lymphadenopathy without breast masses. The left breast is normal. Which of the following is the most likely cause of this patient's skin changes? Pause the video and think of the answer. This patient's presentation is a classic PUD orange rash, which is characterized by a generalized erythematous rash that is often itchy. The skin texture is firm and coarse, similar to that of an orange peel, after which it is named. This rapidly progressive dermatological finding, with or without an underlying mass, and breast edema are consistent with the characteristic presentation of inflammatory breast cancer, a poorly differentiated malignancy with unfavorable prognosis. The term inflammatory is a misnomer because the classic skin findings are not due to infection but are instead caused by cancerous cells obstructing lymphatic drainage after spread to the dermal lymphatic spaces. Due to erythema and diffuse edema, PUD orange can be mistaken for mastitis, although lack of fever and extensive symptom duration point to a non-infectious process. Thus, the most appropriate answer to this question is lymphatic obstruction and not the infectious process. The other options are inappropriate, as in choice A, although it is rare, but the deep venous thrombosis of the upper extremity can occur due to hypercoagulability related to breast malignancy, surgery, or intravenous catheter placement. In the setting of an upper extremity DVT or deep venous thrombosis, edema and pain are localized to the affected limb distal to the area of the blockage and do not involve the skin of the breast. Therefore, this is not the appropriate answer. And delayed hypersensitivity reactions or contact dermatitis is a delayed hypersensitivity reaction that occurs through a T-cell mediated immune response. Macrophages are activated due to cytokine release from previously sensitized T cells, causing a characteristic papular rash. This condition does not lead to tissue edema or induration and is typically preceded by a history of localized irritant exposure. Since it is not present in this case, it is also not the answer. Now, the breast implant surgery requires surgical incisions and can leave scars on the breast skin. Hypertrophic scar is a thick raised and pink fibrous tissue line that follows the original incision. Keloid scars occur due to disorganized collagen deposits and have a thick rubbery appearance that extends outside the incision borders. That is what the scar formation mean. Since there is no keloid formation or any signs of hypertrophic scar, it is also not the answer. Now this slide presents to you with the various type of invasive and non-invasive breast tumors. The first in the non-invasive comes the ductal carcinoma in situ and Paget disease. The ductal carcinoma in situ is characterized by central necrosis, precancerous lesion which are confined to ducts and lobules. Paget disease is characterized by eczematous nipple lesion. It is very much important and it is just the extension of the DCIS into ducts. Next, invasive lesions or invasive tumors include ductal carcinoma, which is most common type, and it involves nest and cords of cells. Next is lobular carcinoma, where we see small cells in single file and involvement of mammary stroma invasion. Next is the inflammatory breast cancer, which is characterized by PUD orange skin and dermal lymphatic invasion. This was the case which we have seen in our previous case. A 3-year-old boy is brought to the physician with jaundice and pallor. He was adopted and his family history is unknown. Laboratory studies shows anemia, reticulocytosis, and increased indirect bilirubin. A peripheral blood smear shows red blood cells without central pallor. This patient is most likely to have which of the following additional findings? Pause the video and think of the answer. This patient's anemia, reticulocytosis, and increased indirect bilirubin are indicative of hemolytic anemia. His peripheral blood smear shows red blood cells without central pallor, that is, spherocytes, which suggests acquired or hereditary spherocytosis. Hereditary spherocytosis is caused by defective binding of the red cell cytoskeletal to the plasma membrane due to mutations involving ankyrin band 3 or spectrin proteins. Acquired spherocytosis is most often caused by autoimmune hemolytic anemia. Compared to normal blood cells, spherocytes are smaller and have a more intensely staining cytoplasm due to membrane loss and red cell dehydration. The red cell index most specific for spherocytosis is an elevation in mean corpuscular hemoglobin concentration. So the answer to this question is C, increased mean corpuscular hemoglobin concentration. The other options are inappropriate because lactate dehydrogenase is an enzyme which is present in RBCs. LDH will be elevated in any cause of hemolytic anemia and it will not be decreased. Next, haptoglobin is an acute phase reactant that combines with free hemoglobin in the circulation to preserve body iron stores and prevent tissue damage. Haptoglobin levels decrease in any form of hemolytic anemia, even with extravascular hemolysis, as some free hemoglobin will spill into the bloodstream. So they will be decrease and not the increase. Next, the mean corpuscular volume is generally normal to low in hereditary spherocytosis and it will not be increased. Thus, the option D is also not correct. Next, the red blood cell inclusions such as Howell-Jolly bodies and Pappenheimer bodies are occasionally associated with hemolytic anemia but are more commonly associated with splenectomy and sideroblastic anemia respectively, and therefore they are also not the right choice. Howell-Jolly bodies are DNA inclusions of the red blood cells, whereas the Pappenheimer bodies are the iron inclusions of the RBCs that is found in sideroblastic anemia. Now this slide demonstrates the spherocytes. The arrow indicates the spherocyte red blood cells and this indicates that there is no central pallor, therefore increase in the mean corpuscular hemoglobin concentration. This is the summary of spherocytosis. The epidemiology can be autosomal dominant inheritance and most commonly found in Northern European descent. Clinical presentation is hemolytic anemia, jaundice and splenomegaly. Lab findings is increased MCHC, spherocytes on peripheral smear, negative Coombs test, increased osmotic fragility on acidified glycerol lysis test, and abnormal eosin 5 melamine binding test. Treatment is folic acid supplementation, blood transfusions, and splenectomy. Complication involves pigment gallstones and aplastic crisis from parvovirus B19 infection. It is mainly the summary for the hereditary spherocytosis. It is not the case of the acquired spherocytosis because of the negative Coombs test, and also the epidemiology says that it is inherited. In this case, a 54-year-old man comes to the emergency department with pain and swelling in the right leg. The patient has no other medical problems and takes no medications. He has smoked a pack of cigarettes daily for the past 30 years. He is a business executive and just returned from an overseas trip. Physical examination shows pitting edema of the right leg and tenderness on deep palpation of the calf muscles. Peripheral pulses are symmetric and full. He is started on a medication that prolongs activated partial thromboplastin time and prothrombin time in a dose-dependent manner, but has no effect on thrombin time. Which of the following agents was this patient most likely administered? Pause the video and think of the answer. Now, this patient has deep venous thrombosis, as can be uh, seen through his clinical presentation, and he is typically treated with anticoagulation therapy for more than 3 months to prevent recurrent thrombosis. Initial treatment of deep venous thrombosis is often with heparin agents, followed by binding to an oral anticoagulant, most commonly warfarin. Additional treatment options also include direct factor 10A inhibitors, example apixaban, and direct thrombin inhibitors, example dabigatran. In general, medications that affect the extrinsic pathway prolong the prothrombin time or PT, whereas inhibition of the intrinsic pathway mainly prolongs the activated partial prothromboplastin time. The thrombin time is prolonged with medications that directly or indirectly inhibit thrombin. Because factor 10A is located at the junction of the intrinsic and extrinsic pathways, direct factor 10A inhibitors both prolong PTT and PT with no effect on TT. So the answer to this question will be direct factor 10A inhibitors. The cyclooxygenase inhibitors, example aspirin, directly inhibit platelet activity and have little or no effect on PTT, PT or TT. So answer A is inappropriate. Direct factor 7A inhibitors are currently in development and work by inhibiting the extrinsic pathway of the coagulation cascade. Therefore, they would prolong PT with no effect on PTT or TT. So, this is also not the answer. Direct thrombin inhibitors prevent the formation of thrombin, resulting in prolongation of all the three, that is PTT, PT and TT. Thus, the option D is also not the appropriate answer. And the unfractioned heparin binds to antithrombin and causes inactivation of several coagulation factors, most significantly thrombin and factor 10A. As a result, PTT and TT will be prolonged. Although the PT should theoretically be prolonged by the action of heparin on the final common pathway, in practice the PT reagent contains heparin neutralizers that minimize this effect, and therefore option E is also not the answer. This picture demonstrates anticoagulants and their mechanism of action. This is the intrinsic pathway and this is the extrinsic pathway. The intrinsic pathway involves the factor 12, 11, 9 and 8, whereas the extrinsic pathway only involves the factor 7. Once with the intrinsic and extrinsic pathway, there is activation of factor 10. The factor 10 then further leads to the activation of prothrombin to thrombin, which then converts fibrinogen into fibrin. The common pathway involves factor 5, 2 and 1. Factor 5 along with factor 10 converts prothrombin to thrombin, which then converts fibrinogen into fibrin. The intrinsic pathway is activated by calcium, collagen, basement membrane and activated platelets, whereas extrinsic pathway is activated by tissue factor, also known as thromboplastin, or by the calcium. This is all for today. Thanks for watching. If you like this video, please do subscribe and share.